Hi everybody, and welcome to our module on cardiac action potentials. The cardiac action potential is a series of changes that occur in the voltage across the membrane of cardiac cells, and these changes are important for a couple of reasons. First of all, they transmit electrical signals through the heart, and in addition, they trigger the contraction of myocytes so that the heart can pump blood. Shown on the screen is the action potential that occurs in atrial and ventricular myocytes. These cells at rest have a voltage across their membrane of minus 85 millivolts. I'll talk about what that means in a minute. They then go through a series of changes in this voltage that is called the action potential, and it's typically divided into 5 phases. First there is phase 0, then phase 1, phase 2, phase 3, and finally it returns to minus 85 millivolts, and that is phase 4. So let's begin by talking about what we mean when we say that these cells have a voltage across their membrane of negative 85 millivolts at rest. Let's imagine that we have a cardiac myocyte and it's sitting at rest. At rest, it has a voltage of negative 85 millivolts across the membrane. What that means is that at rest, there are relatively more negatively charged molecules inside the cell and relatively more positively charged molecules outside the cell. There are pumps in the membrane of the myocyte. They maintain this distribution of ions, and they maintain a voltage across the membrane at rest of negative 85 millivolts. Now let's imagine we have two myocytes that are sitting next to each other. I'll label them myocyte number 1 and number 2. These two cells are connected to each other by a structure called a gap junction. What this means is if myocyte number 1 depolarizes and positive ions enter that cell, some of those positive ions can cross over to myocyte number 2. Because these ions are positively charged, they will begin to raise the voltage from minus 85 millivolts to some higher number, and this will begin the action potential in myocyte number 2. So because of these gap junctions, when one cell depolarizes, it can transmit that depolarization via the gap junctions to another cell, and this leads to a series of depolarizations that travels through the myocytes. So now let's talk about the action potential that occurs in an individual myocyte. So if we have a myocyte at rest, that's called phase 4, and the myocyte is resting at minus 85 millivolts. Via gap junctions, positively charged ions begin to enter the myocyte. This begins to raise the action potential from negative 85 millivolts back towards 0 millivolts. When the voltage begins to rise, this opens sodium channels and sodium begins to enter the cell. Because sodium is positively charged, that further raises the action potential, and eventually a self-sustaining rise in membrane voltage occurs, and this is called phase 0 of the action potential, and it's the result of sodium influx into the myocyte. Eventually the voltage becomes positive, and when this happens, the sodium channels close and potassium channels begin to open. These channels allow potassium to leak out of the cell, and because potassium is a positively charged ion, when positively charged ions leave the cell, that lowers the voltage from some positive number back towards 0. At this point, phase 2 begins. In phase 2, you have competing transmission of ions. Potassium is leaving the myocyte, but calcium is coming in. This means you have positive charges coming in the form of calcium and positive charges going out in the form of potassium. They are canceling one another out, and thus you get a plateau in the action potential that is characteristic of phase 2. In phase 3, the calcium channels close and you only have potassium leaving the cell. Phase 3 is the result of potassium leaving the cell. This drives the membrane voltage back down to minus 85 millivolts, and then we re-enter the resting phase, phase 4. So now that we've gone through the action potential, let me talk about each of the 5 phases in a little bit more detail. The resting phase is phase 4, and this is when the myocyte is at its resting potential of about minus 85 millivolts. What maintains the cell at minus 85 millivolts is a constant outward leak of potassium ions. These leak out through channels that are called inward rectifier channels, and importantly, the sodium and calcium channels, which are going to be important later in other parts of the action potential, are closed at rest. Next, we move into phase 0. This occurs when a nearby myocyte raises the membrane potential via gap junctions. The rising membrane potential opens sodium channels called fast sodium channels. Eventually, enough of these channels are open that a threshold potential is reached. This occurs at about minus 70 millivolts. At this point, there is a large inward sodium channel that leads to rapid depolarization of the cell, and that's what happens in phase 0. Eventually, the membrane potential overshoots and becomes greater than 0 millivolts. At this point, the fast sodium channels close. And an important clinical tie-in of phase 0 of the cardiac action potential has to do with class 1 antiarrhythmic drugs. I talk about these in another video, but they all work by blocking sodium channels and delaying phase 0 of the action potential. In phase 1 of the action potential, the membrane potential is positive and potassium channels begin to open. This leads to the outward flow of potassium and returns the membrane potential to close to 0 millivolts. The key event in phase 2 of the action potential is that calcium channels open. The calcium channels that open are called L-type calcium channels, and this leads to an inward movement of calcium ions into the cell. This is very important because this is the trigger for the myocyte to contract. This is called excitation-contraction coupling. This inward flow of calcium ions connects the electrical activity of the myocyte to the mechanical activity of the myocyte. In addition to the influx of calcium, potassium continues to leak out down its concentration gradient. It does this via channels called delayed rectifier channels. The result is a balanced flow in and out of positive ions, leading to a plateau of the membrane charge. And a key clinical correlation of this phase of the action potential has to do with the drugs verapamil and diltiazem. They are calcium channel blockers that block L-type calcium channels. This can slow conduction through the heart and also decrease contractility. Next, we enter phase 3. In this phase, calcium channels become inactivated. There is a persistent outflow of potassium ions, and the myocyte returns to its resting potential of about minus 85 millivolts. And an important clinical correlation of this phase of the action potential has to do with class 3 antiarrhythmic drugs. These drugs block potassium channels and therefore slow impulse propagation. Let me pause here and contrast the myocyte action potential to the action potential of skeletal muscle. That's what's shown in the screen here. Skeletal muscle also depolarizes by having sodium enter the cell, and then it repolarizes by having potassium leave the cell. Notice, however, that there is no plateau or phase 2. That's because calcium is not involved in the action potential of skeletal muscles. In addition, skeletal tissue does not have gap junctions, so each cell has its own neuromuscular junction. In other words, each cell must be individually depolarized by a neuron because the depolarization cannot travel from one cell to another like it does in the heart. Let me define an important concept that's called the refractory period. This is the time from phase 0 until the next possible depolarization. It determines how fast myocytes can conduct electrical activity. The refractory period begins at phase 0 and generally continues until almost when the cell is back to phase 4. During this period, it's difficult or not possible for the myocyte to conduct another electrical impulse. And many antiarrhythmic drugs work by prolonging the refractory period and therefore making it more difficult for arrhythmias to travel through the heart. Let me make one other point about the myocyte action potential before we move on. Even though this action potential is usually discussed in the context of atrial and ventricular myocytes, you should be aware that you can find an action potential with a similar morphology in some other places in the heart, including the His bundle, the bundle branches, and the Purkinje fibers. But there are two places in the heart where you will not find an action potential that looks like that, and that is in the SA node and the AV node. Cells in these parts of the heart have a different action potential. It looks like what I've drawn on the screen, and this is called the pacemaker action potential. Note that cells with the pacemaker action potential have a slightly higher resting voltage. They do not rest at minus 85 millivolts. They rest at about minus 60 millivolts. Notice also that this action potential only has 3 phases, phase 4, phase 0, and phase 3. Notice that there is no plateau phase to this action potential. And then finally, note that in phase 4 of this action potential, the membrane voltage is not constant, but it slowly drifts upward. The reason for this is because of something called the funny current. This is a slow inward leak of sodium ions. Because sodium ions are positively charged, as they leak into the cell, they cause the membrane potential to slowly drift upward until the cell reaches a threshold voltage of about minus 40 and then it depolarizes. To understand how these cells depolarize, let's imagine that we are a cell sitting in the SA node and it's our job to depolarize and send a wave of electrical activity through the heart. For this cell to depolarize, the process begins in phase 4. In that phase, the funny current is allowing positively charged sodium ions to come into the cell. This is slowly raising the membrane potential. When the membrane potential reaches about minus 40 millivolts or so, this is the threshold for depolarization. At this point in time, calcium channels will open. This creates an inward current of calcium ions, and since calcium ions are positively charged, when they flow into the cell, they will raise the membrane voltage to a point above 0. At this point in time, the calcium channels will close and potassium channels will open. This will create an outward going potassium current, and since potassium is positively charged when it leaves the cell, this brings the membrane voltage back down to about minus 60 millivolts. At this point in time, phase 4 begins again and the process repeats itself. So you can just imagine cells in the SA node going through this process over and over again, and this is how the SA node paces the heart. In the AV node, the action potential has the same shape as what's shown on the screen, but phase 4 is slower. This means it takes cells of the AV node longer to reach the threshold voltage. Before they can reach the threshold voltage, they will be triggered to depolarize by signals coming down from the SA node above. Therefore, even though cells in the AV node are capable of automatically depolarizing on their own, they usually do not do so under normal conditions because the SA node is the dominant pacemaker in the heart, and that's because in the SA node, phase 4 is quicker than it is in the AV node. On this slide, I've summarized the key points about the pacemaker action potential. These cells have what's known as a funny current or a pacemaker current. It is a spontaneous inward flow of sodium ions. This causes phase 4 of the action potential to have an upward slope. Once the cells reach about minus 40 millivolts, that's the threshold potential, L-type calcium channels open and depolarize the cell. When the membrane voltage becomes positive, those channels will close and delayed rectifier potassium channels will open. This will cause potassium to leak out of the cell and return the cell to its resting potential of about minus 60 millivolts. Some other features of these cells you should be aware of. Cells that have the pacemaker action potential are said to possess automaticity. This means they do not require stimulation by a neuron or a neighboring cell to initiate an action potential. They are capable of self-initiated depolarization. This is because they possess the funny current that gives them automaticity. In addition, cells that have the pacemaker action potential have no fast sodium channel activity. These cells have fewer inward rectifier potassium channels. And remember what I told you before, those channels are what make myocytes have a negative 85 millivolt membrane potential at rest. Because pacemaker cells have fewer of these channels, their membrane potential never gets lower than minus 60 millivolts. And those fast sodium channels need a membrane voltage of minus 85 millivolts to function properly. As a result, there is no important role for fast sodium channels in pacemaker cells. Once you understand that this is the action potential seen in cells in the SA node and the AV node, it should be very easy for you to understand that any drug that slows this action potential by any mechanism will cause two effects. First of all, that drug will slow the heart rate. That's because it will slow the rate of depolarization occurring in the sinus node. In addition, that drug will slow AV conduction because it will slow down this action potential in the AV node, and that will delay the conduction of impulses from the atria to the ventricle. And there are two key drug classes that affect the pacemaker action potential and slow it down. The first are the calcium channel blockers that affect the heart, like verapamil and diltiazem, and the second group are beta blockers. Verapamil and diltiazem block L-type calcium channels, so it's very easy to understand how they affect the pacemaker action potential. They slow phase 0, where calcium is important. This will slow the rate of sinus depolarization. Anything that slows this entire action potential down will slow sinus depolarization, and that will slow the heart rate. In addition, they will slow the conduction of impulses through the AV node from the atria to the ventricles. Beta blockers have a couple of effects on the pacemaker action potential. They slow the sinus rate by modifying the slope of phase 4. Let's take a look at these two action potentials on the screen. In blue, I've drawn one that might represent a normal SA nodal cell. In red, I've drawn one in an SA nodal cell exposed to a beta blocker. You can see that there is a slower slope to phase 4 in the cell that is exposed to a beta blocker. A slower slope means it takes longer to reach the threshold and depolarize, and therefore there will be less depolarizations per minute, and this will lower the heart rate. And this is the mechanism by which beta blockers slow the heart rate by slowing depolarization of SA node cells. Beta blockers also prolong repolarization. You can see that this action potential for the beta blocker is longer and wider than the action potential under normal conditions. This is going to slow action potentials in the SA node, but it's also going to slow action potentials in the AV node. That will slow conduction from the atria to the ventricles. I told you that beta blockers modify the slope of phase 4 in the sinus node, and this is how they modify the heart rate. And you should be aware that there are a number of different things that change the slope of phase 4 among cells in the sinus node to modify the heart rate. Things that decrease the slope, leading to a slower rise in a lower heart rate, include the parasympathetic nervous system. This is how the parasympathetic nervous system modifies heart rate. We've already discussed beta blockers, and the antiarrhythmic drug adenosine also lowers the slope of phase 4. And then there are some things that increase the slope of phase 4, leading to a faster rise in membrane potential and a higher heart rate. This is the way the sympathetic nervous system speeds up your heart rate as part of the fight or flight response. It's also the way that a number of sympathomimetic drugs function. And then finally, let me mention that there are a number of pacemakers in the heart other than the SA node. There are many cardiac cells that are capable of automaticity. However, as we have already discussed, the SA node normally dominates. That's because it has the fastest rise in phase 4, and therefore it controls the depolarization of other pacemaker cells. However, if the SA node fails for any reason, your heart will not stop. There are other cells that will take over the role of pacing the heart. The SA node is the fastest pacemaker, that's why it's usually dominant, but after the SA node, the AV node is the next fastest pacemaker, followed by the bundle of His. The Purkinje fibers can even potentially pace the heart, so can the ventricular myocytes under some conditions. The SA node, you may know, under normal conditions paces the heart at a rate of 60 to 100 beats per minute. The AV node can only do this at about 40 to 60 beats per minute, and the His bundle is even slower at about 25 to 40 beats per minute. And that concludes our module on cardiac action.